Good morning, everyone. This is Kimberly Hendricks, and we're going to get started with our Health Policy and Analytics, Public Employees Benefit, and Oregon Educator Benefit Board meeting. So the Innovation Work Group for March 16th is going to start, and I'm going to do roll call first. If you guys could turn your cameras on and let me know if you're here. So Robert Young, I can see you. Good morning.
Here.
Good morning. Greg Clauser, good morning.
Good morning.
Sally Deerfield. Let's see, Sally.
Looks like we might not quite have Sally quite yet.
Okay, perfect.
Yeah. Oh, I was going to say I saw someone hop on, but no, not quite Sally yet. So
okay, perfect. Sean Parkman.
I'm here. Good morning.
Good morning. All right. Well, we will notice when Sally jumps on, but we'll go ahead and get started. First order of business is, did someone want to make a motion? I assume you all had an opportunity to review the minutes?
I can make a motion if nobody
I
has
move that
any.
we accept the minutes as written.
Okay, so we've got a first by Robert and a second by Greg. Is that correct? Okay. Sean, how do you vote for accepting the minutes?
I vote yes.
And then I will also, because I think we need me or not. Any question, comments? Okay, I think the minutes are approved as written. Thank you so much. And we will get started. Welcome, Mercer. And is it Cindy is going to be our presenter? I'm sorry that I didn't pull I always use Rose's agenda online.
absolutely. Hey, Kimberly. I was going to say, it's Margaret. We were going to, as our next agenda item, do our quick leadership transition.
Oh, okay.
And I wanted to note that Sally did just join us just a couple of minutes ago. So we do have all 5 work group members here. So first off, I just wanted to take a few minutes. Thank you to everyone for joining on a Monday morning. I know we typically hold these meetings Wednesday afternoons, so this was a little bit of a shakeup to the schedule right at the beginning of the week. So appreciate everyone being here. And just kind of wanted to recap. So for the past couple of years, the Innovation Work Group has had a little bit of a variable meeting schedule. And Kimberly Hendricks as chair and Robert Young as vice chair have been really engaged and flexible as the work group's efforts have progressed and our meetings through the course of the year have occurred. But it has been about 2 years since spring of 24 when they both took the helm. And so we are at the point now where it's time to transition leadership. And we have had 2 work group members raise their hands and volunteer to step into those roles. Sally Deerfield has graciously volunteered to serve as the next chair. And Sean Parkman has volunteered to serve as the next vice chair. So typically, this work group sort of operates in a consensus approach in terms of decision making. So I would ask for work group members to feel free to chime in with any comments or thoughts they'd like to share, and then seeking work group consensus to move forward with the new members as chair and vice chair.
Thank you, Margaret. I'll use my chair one last time. And I just, thank you, Sally and Sean, for really being responsive and saying that you would step up and continue the work. I know that Sean has been here since the very beginning for Innovation Work Group, and it's very dear to his heart. So there was no way he was going to let this not have leadership backing and kind of the knowledge behind what we've looked at, what we've already been there, done that. So we keep moving forward as a group instead of kind of redo NASCAR a little bit there. So thank you all so much. And, between, the support you get from Margaret and obviously Rose taking care of us behind the scenes, it'll go very smoothly. And then, Robert, thank you so much for stepping up to be co-chair with me. I sure appreciate it. So, it's been a pleasure, and I look forward to just being in the audience instead of having to make sure that everybody's there. So thank you.
Thank you, Kimberly.
Fantastic. So, and I will say, I've staff and Mercer have met with Sean and Sally sort of offline already, and they are diving in headfirst and really ready to take it away. So, very exciting to have the work continue and have these really engaged members, continuing to be part of the conversation. So I do believe with that, straightforward enough. At this point, we are ready to dive into our data heavy agenda. So we will turn it over to Mercer, and I do believe Cindy Crozier from the Mercer team is going to be first up, talking specifically about Garner program, a little bit of data on program experience to date, as well as strategy for ongoing performance measurement of the program.
Good morning, everyone. I'm Cindy Crozier. I'm one of the registered nurses on the Mercer Well team here at Mercer, and have been supporting our core team on the IWG for a couple of years now from a clinical perspective. We can go ahead and jump to the next slide. And so just going to talk briefly about background and current performance of the program, and then we're going to jump to sort of our proposed measurement strategy, and then lastly we'll chat about next steps. We can jump. Next one. Okay, so just for background, Garner was brought to OEB and PEB spring of last year as a program that could potentially provide some savings through steerage of members to more efficient providers, higher quality providers. And then members who chose a Garner top provider would ultimately receive reimbursement for their out-of-pocket costs. So that was sort of the incentive to drive utilization of those providers. And so, higher quality, but also more efficient, lower cost. OEB implemented the Garner program October 1st of 2025, and PEB implemented January 1st of 2026. So for this current plan year, both OEB and PEB have Garner in place. We can jump to the next slide. So this was a little bit of current enrollment and utilization. So you can see OEB and PEB both listed there. Timeframes are a little bit different just based on the launch of the programs. So far, the sign up for Garner for OEB is at about 25%, which is about 6 months in, almost 6 months in. And then for PEB, about 20%. So really good uptake on the PEB side in that initial sort of 3-month period. The goal for year end is around 40% for both programs. I know that the performance guarantees, I believe, are tied to a 30% minimum. So definitely looking to hit that 30% target, and does appear that we're on a good track to reach that. The number of families who have received a Garner top provider recommendation, so they've signed up for Garner, actually gone on and looked for a provider and received a recommendation, about 22% on the OEB side and about 17% on the PEB side. So looks very similar there as well. Those who've actually utilized a top provider, about 9% for OEB as of 2/26, and on the PEB side hasn't really been reported yet. as of 2/19. We haven't seen the utilization yet. And then for those family units who've actually used a provider and then received a reimbursement, got about 7% on the OEB side of that 9%. And then about 163 individuals have received the reimbursements on the PEB side as of 2/19. Again, the reporting time frame is just a little bit different, which is less than 1%. So any questions on that? Hope not, no. So we just wanted to kind of ground everyone in sort of how Garner looks at the total cost of care and to identify top providers. And they do look at a number of different categories, definitely look at site of care. So are providers using lower cost sites of care, so ambulatory facilities versus hospitals for procedures like colonoscopies and high cost imaging. So are we using a freestanding radiology center versus sending everyone to the hospital outpatient department to get their CT scan or MRI, knowing that those are lower cost sites of care? Pharmacy utilization, also looking to make sure that prescriptions are compliant with the formulary, that generic drugs are used when possible, that there aren't compounded drugs that are easily purchased over the counter, for example. That would be another way that we know that they're being more efficient. The type of procedure or surgery, so minimally invasive procedures where possible, so laparoscopic surgery, for example, versus an open incision. And then medical utilization, we like to see surgery avoidance for procedures with uncertain values. So things like spinal fusions, hysterectomies, things like that. So not that those procedures would never occur, but that we would see that there are opportunities to steer folks with spinal fusion, where spinal fusion would be a possibility. We're steering them to things like physical therapy, pain management. So looking for those strategies, making sure that we've got all of the appropriate testing ahead of any type of surgery to make sure that surgery is actually needed. And then the cost per service, so looking at physician referral patterns. So for example, our PCPs managing as much of the chronic condition population as they can under their license, not just referring everybody out to an endocrinologist, but really trying to manage what they can in the PCP practice. And when they do refer out, that they're referring to high quality, highly efficient providers. And then also just physician facility per procedure costs. So kind of looking at total cost of care. Any questions there? And I would like to say that just when we think about being efficient, it doesn't necessarily mean being the cheapest. It's really looking at these things like referral patterns, using the lowest cost drugs and the lowest sites of care that make them more efficient. Also meeting quality standards and having fewer complications down the road also would make them more efficient. Okay. Jump to the next one. I think I'm going to turn this over to Emery for a slide or two.
Thank you. So one of the big things that big reasons why Garner was implemented was to essentially save money, right? OEB and PEB, the costs are going up, trends going up, and we managed to a 3.4% limitation. So there were projected savings, and these figures are from Garner, and you can see they were from the renewal cycle from last year. But on the left-hand side, you can notice the savings for OEB. The claim savings projected by Garner was about a little bit less than 17 million. The admin fee would offset those savings, and so that'd be a cost of 2 million and 2.75 million. HRA funding, the incentive that the members would receive was projected to be about 5 million. So the net overall savings in this case for OEB would have been about 9 million based on what Garner projected. There is that guaranteed savings that Garner's providing that requires the 30% sign up with Garner, as mentioned before by Cindy, 25% for OEB. Once that is met, and then essentially guaranteed savings of about 2% of capped medical spend for OEB. So those were some of the figures provided by Garner and part of the reasons why they were implemented. On the PEB side, you can see on the right-hand side, the potential savings, 19 million under Providence, and then a little bit under 7 million for MODA PEB. The admin fee is about 3 million, and then the HRA funding is going to be about 6.5 million. So the net savings would have been closer to about 16 million for PEB. And then the guaranteed savings down below. So those figures for PEB, we're hopefully we'll see those guaranteed savings, but that's part of what we would like to analyze as we, propose this Garner recommended monitoring report. Next slide, please. And so why are we developing this oversight strategy? It is a big program, right? And it was adopted by the two plans to OEB and PEB to improve health outcomes, as Cindy has mentioned. You're trying to find those higher quality providers, and we want to see if that's actually happening and if they are better outcomes. We want to have transparency and understanding, and to see, for members to see that, these are the other members that they work with, their co-workers are getting higher quality providers and they're more cost effective. And then so that helps, demonstrate the value of the program to each of those members, and hopefully increases the overall usage, and then can hopefully demonstrate and bring down costs, long-term costs for OEB and PEB. This strategy hopefully will also support member behavior changes, so it can be provided as information, not just talking, but like to your coworkers, but also like maybe some communications to them overall from staff to the members. And then it's also to just make sure that we are monitoring that the outcomes are being achieved. The savings is obviously a big thing, but we also want to see better quality. And hopefully what we're proposing will demonstrate that to IWG as well as the board members. Cindy, is there anything else you want to add before we move on?
No, I think that's good.
Okay, I'll turn it back over to you.
Okay, we can jump to the next slide. So basically our proposed measurement categories sort of line up very nicely with the triple aim. So we're looking at member experience, improving the member experience, health plan savings, and then also improve clinical outcomes. And so that's sort of how we've split up our measurement categories for Garner. Jump to the next one. So the first one's sort of that member impact. A lot of the savings most of the savings are generated from members shifting from less efficient, less quality providers to higher quality, more efficient providers. So definitely looking at those sort of leading indicators around things like enrollment, how many people have signed up, are they engaged, are they using resources to identify higher quality providers, we're also really interested in evaluating sort of who is signing up and who is making those behavior changes. So what are the demographics, the risk levels? Is it certain regions of where members are located, or are we seeing older members using the tool more than younger members? So sort of looking at kind of all of those things, gender, race. We want to make sure from a DEI perspective that we are seeing uptake by populations where this would really provide greater access and higher quality. And then finally, we want to look at sort of that use of the top providers. So are folks, primarily gravitating, are they identifying high performing primary care providers, for example? Are we mostly identifying high performing specialists? Are there opportunities, or are people actually moving their site of service from an outpatient hospital to an ambulatory surgery center? So kind of looking at all of those things around the member impact. And we feel like that's a good way for us to be able to see, are we changing member behavior? Any thoughts on any of that? Sorry, go ahead, Emery.
That's okay. Some of this information will be available through our claims database for OEB and PEP. Some of it will have to be through Gartner, in terms of the call center contacts, in terms of what they're engaging there for. Those will be from Gartner, but a lot of the other information, we will get the data feed from Gartner that will be able to be melded with the database, and then we can then hopefully mine it, provide some reports that kind of shows these breakouts, as Cindy has mentioned. Sean.
Yeah, just a little context and reminder to the committee. Not that long ago, a couple of years ago, we took a swing at centers of excellence and this kind of work. And the point of that is similar. Not the same, but similar to what Gartner's up to and promising, which is, finding the quote unquote top providers who are the most efficient, lower cost, but they're higher quality. And just to put an emphasis on that was not an easy activity. We have a lot of data, and the devil's in the details, like figuring out what we mean by best quality, quote unquote, top providers. What does that mean? Using what metric, which data, so on, was a heck of a thing. And ultimately limited us in how many things that we could do and how strict we could be in this and that. So just, you're saying this, but I'm just putting an emphasis on it. Gartner has a proprietary mechanism by which they determine this quote unquote top providers. And so we don't get an insight as the board into exactly how they come up with that and so on. Hence the data checking activity that we're discussing here, which is can we triangulate in some way and just be like, so how's it going? And who's using it and so on. And I'm just emphasizing, given the amount of ink that was spilled in our efforts on that and how extremely difficult it was, it's worth having a very close eye on how this plays out, because it just will be interesting that they will have a way of getting at this that we did, in a very clean, very clear way. That would be interesting and useful to know. So it's worth just watching this like a hawk, because we need to know how does it actually play out, because there's a lot of resources in play here around this. So I was just adding that for context and for what it's worth.
Yeah,
Thanks, Sean.
and yeah, thanks. Cindy, was there something you wanted to mention? Oh, okay. Yeah, I mean, in terms of what a top provider is, yes, it was definitely a lot of effort on the COE portion of it. This is what Gartner does. I think the next couple of slides will hopefully kind of get a little bit more granular as to what we're trying to look for to see if those are truly top providers that members are seeing, and what's the service difference. This slide is a little bit more on is the communications aspect of it, how well the program uptake is. But we will definitely, try to, I don't know if it parse out, but at least see if we can see the elements of what Gartner's proposing and whether it's showing up for OEP and PEP. I don't know, Cindy, if there's anything else, if you want to kind of go over to those other measurements.
Yep. If there are any other comments or questions, we can jump to the next slide. This was just some preliminary information for what members are actually looking for when they do go on the Garner app and they're looking up, a quality provider. One thing to note is that primary care is not on this chart. It was the top category, and the line would be very long. So we pulled primary care off the top, but it's interesting that the top 4 categories after primary care are the same on both sides. So dermatology, therapy, OBGYN, PTOT. So interesting that there's a lot of similarities there, and then orthopedic surgery is up there pretty high. But you can see folks are out there looking for specialists across, a pretty broad spectrum. So that's what we want to see. Okay, we can jump to the next one. So the second category that we have in our measurement strategy is around savings. And, of course, savings is sometimes difficult as we move members to higher quality providers. Ultimately, there is downstream savings that we see from that when they are not using emergency room or being admitted as frequently, these types of things. But it's sort of hard. Sometimes those are avoided costs, and so those are very hard to quantify. So just looking at, how would we look at the impact of cost? We can look at episodes of care. So think about things like a knee replacement, and if a member has that performed with a Garner top provider, what does the cost and outcome look like based on that versus members in the plan who maybe didn't use a top provider? Total cost of care for members, so per member per year, that kind of thing, adjusted for risk and demographics, sort of looking at those who utilize the Garner program versus those who don't or who utilize Garner top providers. And then those member incentive payments. The potential for savings goes up as those incentive payments goes up as well, because we know we're getting folks to higher quality providers. So sort of looking at the impact of that and how much that erodes the savings. And then claims and utilization, again, those high quality. So just looking at, ER visits per 1,000, admissions per 1,000, length of stay, even things like complication rates, site of care. So looking at lower cost sites of care again. And then potentially we could look at trend long term, once we get some experience under our belt. For folks who are using Garner top providers versus those who aren't. And then we could at some point also do a matched cohort study where we would actually try to very closely match users versus non-users to make sure that they look similar in terms of demographics, risk score, conditions, utilization, all of that, to see if we see a different impact on folks who are using those Garner top providers. Any questions there? Okay. We can jump to sort of our last category, which are the clinical outcomes. And I think these are hopefully going to be a little easier to quantify than some of those avoided savings. So our proposal is to focus on the NCQA HEDIS measures. We know that these are well-established, utilized very broadly in the healthcare system, recognized by everyone. Not a lot of pushback from providers and facilities, things like that, because these are kind of the gold standard. Whoops. Out of the HEDIS metrics, we selected 11 to propose for measuring the clinical outcomes, and we had to be a little bit thoughtful about this. Some HEDIS measures require chart review and things like that, or results for lab work. So things that wouldn't be easily, we wouldn't be able to get to easily in claims data. So we tried to focus on those where we would be able to use claims and encounter data to calculate those outcomes. The other great thing about HEDIS is that there are lots of benchmarks out there, benchmarks by plan, benchmarks by like the 50th percentile, the 75th percentile. So we've got lots of benchmarks and would be easy to see movement, I think, and where Garner participants versus non-participants maybe are falling out. The first measurement year would be 2026. And then we also would consider looking at some pharmacy measures like drug formulary and opioid prescription CDC guidance. So looking in the claims, are we seeing prescribing patterns that are consistent with CDC guidance, or are we seeing, sort of off CDC guidance prescribing patterns, those types of things. So if you go to the next slide, we listed these 11 HEDIS measures. The ones that have a star next to them are where there's actually a performance guarantee metric that's aligned with that HEDIS measure as well. So, looking at things like statin therapy for folks who have heart disease, are diabetic patients getting their eye exams, their statins, are they getting their kidney evaluation each year? We can jump to the next slide. Use of imaging studies for low back pain. So we'd like to see folks who have low back, acute onset low back pain, if they don't have any what we call red flags, so no, like weakness in their lower extremities, for example, or incontinence or something like that, where we would immediately say, oh, you have to go right away and have a scan. But in most situations, those will sort of, those little acute injuries will resolve independently. So we like to see a primary care provider. That's usually where folks start, not rush to get an MRI right off the bat, that kind of thing. Again, around opioid prescribing, are we seeing multiple providers? Looking at well child visits, child and adolescent well care visits. We would also look at adult well care visits. And on the next slide, age and gender appropriate cancer screening, so breast cancer, cervical, and colorectal. So any questions on that, on the HEDIS measures?
So a lot of these metrics, are being provided, the plans have to do it, and they are part of the performance guarantees. The splitting out between top providers and non-top providers obviously is not part of the performance guarantee. I think for a lot of these, we are maybe taking a look at a little bit more claims-based, and so we might, Mercer might be doing that sort of analysis. It won't be exactly the HEDIS metrics themselves, but we would be doing our best effort to mimic that. Split out between the top providers, not top provider, the members who are not seeing those using Garner versus not using Garner. So, but I don't know if Margaret, if you want to put into like the performance guarantees or anything like that, but maybe we could also ask the plans to maybe see if they could flag it and then provide those quality metrics broken out. But it's just depending on what's probably the best way of doing it. We'll figure it out, but no plan.
Yeah. And Emery, you're right. A lot of these measures are very familiar because they are the clinical quality measures that carriers report annually, and we've had under performance guarantee for a while. So I think particularly in the initial year, there will probably be some refinements we make along the way as we start to sort of like try to look at these measures for, say, the population of members who see top providers versus the population of members who aren't using the top providers. And, I mean, just right out of the gate, I think, the hypothesis would be that there would be somewhat of a higher level of performance on the measures for the top provider cohort as opposed to the cohort of members who is not using top providers. And so I think going into it, it's part of it will be to see how that hypothesis plays out. And Sean, yeah, your hand is up.
Yeah, the other element that seems worth maintaining is, from our experience doing some of this before, was many of the providers that we would think of as top providers were already booked. Like they don't have a lot of empty space in their clinical calendar. So just on the terms of centers of care, they didn't need us, to have some extra program driving people to this. Yeah, we're booked, we're good. And so we just want to keep a track of if that's what Gardner's doing, and they're pushing people towards those providers who are already full. And then that causes like increasing scheduling time and that sort of thing. We just want to keep our eye on it. So, because I think the last time we looked, capacity was already pretty full.
Yeah.
So,
Well, yeah, and certainly in a lot of providers, you're right. Scheduling is tight. Part of Garner's algorithm to identify top providers does look at access, basically availability. And I'm not going to get too technical here because I don't have the exact algorithm, but they do, when they look at the claims for top providers, they do track to make sure that new appointments are appearing within a certain period of time within the claims data. They sort of use these claims indicators for new patients when they're tracking to make sure that there's evidence that these providers do in fact actually have new appointments available and are, taking in new patients. So that if a member were to search Garner and identify a top provider, they would likely, in contacting that provider, have the option to access a new patient appointment. And the specifics in terms of exactly how that's done in the data are sort of outside my expertise, but it is part of Garner's approach to building that top provider network is making sure that they are providers that are actually taking new patients. And Robert, yeah, go ahead.
Yeah, just a quick question. Is there a capacity difference between primary providers and specialists? I mean, I definitely hear what Sean's saying, but is it primarily on the primary side of not being able to take new people, or is it across the board?
My sense is there's probably not one answer. It probably varies by community and by specialty. So I don't know. I'll look to others in the meeting if anyone has any sort of expertise on that, but I don't know that we have a real hard and fast, clear answer in terms of, I mean, we are certainly hearing, I think, in many parts of the state that it's really hard to get into primary care. Like if your primary care doctor retires, it's going to be a while before you find a new one, that sort of a thing we're certainly hearing. I can't say, I think on the specialty side, there's probably a range of experiences and there's probably some geographic variation in that as well.
Yeah. Robert, as we were looking at Garner and I think probably looked at it, but as a consultant for PEP, that's where I got the information. But Garner did provide essentially kind of like a time and distance, right, for certain providers in terms of where certain top providers would be and where they would have issues finding top providers. I think Klamath Falls was one of those areas where I think there might have been one or two specialties where there might have not been a top provider. But overall, I think it was relatively good coverage across the state. The question about whether you can actually get, in a meeting appointment within reasonable time, that is part of Gardner's algorithm, as Margaret said. And if we hear anything, we'll definitely let you know. If you hear anything, let us know. I'm not sure I mean, we could put more effort on the plans to kind of maybe have them do some secret shoppers on some of that, expand it beyond behavioral health to like primary care and some other highly utilized specialties. But, I think we're not going to be able to get that for right now. We'll have to just kind of rely on word of mouth and seeing, whether there are any issues, just like noting here or there. But if we find anything, if we hear complaints, we'll definitely know them and let the boards know.
Well, I think the last bit we had was the next steps. So, basically, if you take this back and you have thoughts and feedback after this conversation, we certainly want to hear everyone's feedback on this approach. Just looking at the HEDITS metrics being measured on a calendar year versus other metrics, which would be measured on the plan year. So, any final thoughts on Garner?
So we do have about 6 years of claims. So we can definitely do a longer look in terms of the information based on the claims. And hopefully we'll be able to provide some information. I mean, it's going to start out with probably a lot of information that Garner's has as the claims run into the database. And it's going to be a lot of member impact, member usage. And then as we move on to getting a full year of claims, then we'll start getting more of the savings and utilization impacts. And they might not be able to be parsed out exactly. We do expect a relatively large base of Garner utilizers. So I think credibility should be decently good overall. Maybe a little tight on some of the specialties, but hopefully we will be able to see something and to demonstrate the value that this program is bringing to both OEP and PEP.
All right. Well, thank you very much.
Yeah. So I don't know. Kimberly,
Yeah.
Margaret, I
I
think
was
we
gonna
are
say
a little early.
yeah, and we're kind of
What do you
just
want to do?
making that transition between Kimberly and Sally as our chairs. So we are early. We're running ahead of schedule. The agenda has a break at 10:40, which is, it's 10:12 now, so we're ahead of that. Um, I guess I'll look to the work group members. Would you like a quick break now before we jump into the next presentation, or is everyone feeling pretty set and just wanting to charge forward?
Let's take a break now.
All right, great. Let's do a 10-minute break now. So back at 10:23.
Hi, Margaret. Are we all ready? Turn back over to Sally to kick off part 2.
Yeah, I do believe we are all back. I see cameras on. And yeah, Sally, if you want to take the agenda.
Sure. Yeah, let me pull that. I mean, I've got it up on my end, but
Yeah.
okay. So I think next up is right, the March 2026 IWG leveraging purchasing power.
Yeah.
Right. And
Yep,
this will
that's it.
be led by Emery.
Yep.
All right.
Okay. Thank you, Chair. All right. So this is essentially part 2 of, I don't know, like a multi-part series on leveraging purchasing power. We can move on to the next slide. So we'll kind of just recap what we discussed initially, I believe in December, and then we have a few potential opportunities that we're talking here. And it's we'll see. Like, definitely let us know your thoughts about how you might want to proceed on some of those, or your thoughts around what we're suggesting. And then next steps, we'll follow up with next steps. Okay, moving on. Okay, so the IWG, I mean, we are looking at data to try to improve the quality of healthcare and reduce costs, kind of similar to what, taking a look at what Garner does and to see what they're doing. But this is also a way to try to reduce payments, right? To reduce trend for OLEP and PEB. I mean, as trend continues to increase and renewals come in higher than 3.4%, we need to figure out ways to make sure that costs are kept low, and so that members aren't going to have to pay much more out of their own pockets to essentially cover, make sure their health is good. There was a letter from the governor about a year ago reaffirming interest in trying to bend the cost growth, bend trend. And we started that conversation. And today, as mentioned, we do have a few potential suggestions, potentially actionable interventions that we can talk about to hopefully reduce costs and to use the power of OWEB and PEP. Okay, moving on. Just a little recap of the meeting. OWEB and PEB, it's pretty big. 300,000 members or so, maybe a little bit more than that. About 8% of the total population in Oregon, although some are out of state, but is generally in Oregon. So there is some power to influence, and some of the changes that happen for OWEB and PEB, especially like the 200% of Medicare limitation, has been very powerful in terms of reducing costs, not just in Oregon, but other states as well. There are more and more states. I don't know how many states Margaret has talked to about reference-based pricing, but it's happening all over the place. New Mexico, Washington. I mean, there's failed attempts in North Carolina, and Montana had an attempt for a while. So, and as we will talk, moving in later in the slide, Vermont's doing something that essentially we suggest that OWEB and PEB look into. So there's definitely been growing influence on using either probably legislation more so than anything else to try to limit what the payments out on behalf of school teachers and employees of the state. But there are definitely barriers. The health system concentration, especially in rural areas. I think in the metro area, you have a lot more competition, more different network between MODA and Providence for PEB. In the metro area, because you do have different health systems competing. But once you get outside the population basis, it does become essentially a one hospital town for many people, and maybe one provider system town in terms of like physicians and others. So there's definitely some strengths for those providers in that case. Complexity, market complexity, healthcare is very complicated, many different elements, and everyone has their own interests. So definitely it creates a barrier here. And this other bullet, desire to preserve status quo for members. It is something that has been, a strong interest of the board members. And Sean had brought up the COE earlier, and that was one of the things that I don't know if I want to say, has like made it very difficult for the COE. It's like trying to protect member choice. Um, that is something that's definitely a goal, and it's something that we're you want to keep in mind, keep as much member choice as possible. But sometimes, especially in situations where you do have to, potentially cut a lot of costs, unfortunately, I think you run into that tension, right, between availability, access for members versus what you're limited to in terms of dollars. And you have to have that trade-off, consider that trade-off between how much you're willing to pay to retain that choice. And we're not here to make that decision. We're not here, we can discuss it, but that's something like I think the boards need to consider on their own. But there are, in order to save money, potentially you might lose some, access. And that is something that needs to be considered. And unfortunately, it is that something to be considered, needs to be considered as we move forward, especially when we're considering trends of 9% plus. You can't cut 5-6% off every year or hope the experience is going to be better. It's just over the long term, it's, unfortunately, 3.4% limitation is much lower than what is currently happening in healthcare. So those are some things to consider as we go through some of the discussion and possible interventions. Any comments or questions before we move on? Okay. Next slide, please. So let's talk about some potential opportunities. This is a variant of the slide we presented in December. It's essentially the sphere of influence. There's various areas where we can talk about trying to leverage purchasing power. It's payment reform is the one on top. We do have provider delivery, and if you go back to the December presentation, we talked about some ways that states have done, especially Tennessee, on trying to change the way care is delivered. One area where provider delivery was also, I think, very impactful is the PCH program, right? That was a big program. It helps drive some of essentially, coordinated care, and I think has been very helpful in terms of managing and improving care in Oregon. But it is a bigger thing, and the number of the interested parties, number of people who have to be involved and to drive that is definitely pretty big. Member interactions is another way you can try to influence how leveraging purchasing powers, like change where members are accessing and how they access healthcare. Garner is definitely one of those member interactions. We do talk a little bit about high performing networks, which would also be a member interaction. But it does involve, again, potentially reducing access to some providers in order to drive members to those providers who have to providers who are better care, lower cost. And so there would be some disruption to members in that case. But I think one area where we've definitely seen action and improvements in savings is up top, payment reform. It's probably the most straightforward. It's like, okay, we just want to pay less, right? It does take potentially an act of legislation, have the legislators to do that, but you could potentially also say for these services, we don't want to pay more. And that has been done by OIP in the past, and it had been impactful in that case. By doing that, it also helps support price transparency. So members do have a better idea of what they're paying. Providers have a better idea of what they're getting paid. And, health systems or insurers understand what, maybe helps them in the contracting in that case. And also, it definitely has quicker impacts, right? Once that legislation for the Senate Bill 1067 came in, it was a immediate one-time thing, although, we did have the adjustment to it, but essentially it's a very quick impact, and it's not like a longer term thing like some of the provider delivery or member impacts. Those do potentially maybe reduce trend over time, but it is a longer time frame. Your impacts are going to be a little bit slower than just basically saying this is the level we're going to pay at, essentially, or this is how we're going to pay for services under payment reform. Any comments or questions before we move on? Okay. Next slide, please. So this first section, it is what we labeled reference-based pricing. So it's kind of like, as mentioned up there top, it's essentially what Senate Bill 1067 did, right? It's a hospital reimbursement cap, which is reference-based pricing, saying we're only going to pay 200% of Medicare. You set that reimbursement strategy based on essentially a transparent amount, or a system of pricing something, which in this case for Senate Bill 1067 was Medicare. And that's essentially the cap of what you're going to pay. 200%, 150%, or even lower, depending on what type of service you're looking at. Medicare is the largest, and it's essentially the most transparent way of pricing. There's definitely, everyone can look and see what CMS has for the formulas. They can try to create their own Medicare pricers. It's out there. There's companies that do it. And it's a benchmark that's pretty easily understood and accepted. And as, discussions have happened, especially with states, it's like, this is where I think a lot of people are focusing their interests or focusing what they're trying to do. It's targeting payments to Medicare in this case. So state Medicaid programs do set reimbursement at many service categories at 100% or of Medicare or below. OHP does that for their facilities. I think they target 85% for the Medicaid program. And then you can also set upper payment limits at Medicare equivalent rates in this case. And there are other programs, third party like Point Solutions, COEs that essentially either translate to a percent of Medicare in terms of what they're contracting with, or actually set targets as a percent of Medicare, because it is easier for people to understand. And it gives you a reference for how much you potentially could save compared to what your current payments are at. So a little background on reference-based pricing. And with that, we do have some, next slide, please. We do have a potential option. This is tied into a law. If you take a look at that middle section of Vermont state law that just came into play, that's effective beginning 1/1/26. It caps payments for medical pharmacy at 120% of Medicare. For Vermont, it's savings of $14 million. I think there was a presentation we saw. It saves more potentially for certain insurers in Vermont, but essentially they're capping payments at 120% of Medicare. That is well below 200% of Medicare. And one thing that we've seen for Oregon is we've done the hospital monitoring and also looking at the claims, with the cap at 200% for outpatient facility, for some of those facilities, some of these medical pharmacy services are being paid at 200% of Medicare because that's their cap and that's what they're contracted at. Medicare pays medical pharmacy essentially at 106% of the average sale price. So basically, the average sale price plus 100% is you're paying what? You're 100% profit plus. So Vermont's capping that to more of a 25% cap profit on certain services, which are at the top, drugs that are essentially administered in the hospital, outpatient department, physician offices, or other places, especially including the home sometimes. So if there's some site of care things, I think with medical pharmacy, with MODA, and I think Providence to administer services in the home for, and those would be essentially J codes. Those are the types of services we're talking about. Includes some biologics, CAR T, chemotherapy, and some other services here. So what are we proposing? Oh, go ahead, Sean.
Sorry, you go ahead. I'll say my comment.
Well,
in a
yeah.
minute.
So basically, what are we proposing? Maybe taking a look at 100%, 20% of Medicare cap on medical pharmacy. So do something similar to Vermont, and how much would that save? And it'd be 15 to 25 million annually based on essentially the most recent claims data and what we have for percent of Medicare payments. Medical pharmacy is growing, right? They're growing. They're pretty big services. They are now more and more multi-million-dollar services. One of the first ones was Zolgensma. It was charged at $2 million. So if you pay 200% of Medicare or the sales price of $2 million, that's $4 million, right? So that's an additional $2 million potentially that would be going out of OEB or PEB's pocket. And more and more of these services, the new medical pharmacy costs are millions of dollars. And Sarah Drake's on the line, I believe, and she can provide more detail around some of these, but they are definitely very expensive. Sean, go ahead.
Yeah, I was just going to say a few things. One, I'm really excited about this idea. I've been surprised, frankly, of how effective our 1067 reference-based pricing has worked, and that's been encouraging to watch that over time. That other states are experimenting with this is encouraging. It's interesting. I also want to point out, just for the sake of history, that one of the purposes of this committee originally was for the committee to be a data-driven think tank that occasionally surfaces ideas to the legislature that they may want to consider. And that came about because the legislature was at a moment where it wanted to do something to contain costs. It was very critical at that moment. And they started proposing and pushing buttons in all sorts of directions that were related to OEB and PEB. And some of us on the board was like, oh, hold on, because a lot of their ideas, would have been very impactful. Anyway, so there was a proposal like, we're going to create this committee where we can workshop some of this stuff with some data consultants, and then we can surface things. And that was a deliberate way of discussion related to how this committee came about with the legislature. So I also just want to point out that that's appropriate. That was the original intent, is to surface ideas that may or may not, depending on the idea, require or include some legislative participation, and obviously that it's up to them to make decisions, but at least to surface ideas that give them options was something that was intended. So that was really what I wanted to say, just a little context there about that. And then also just I think it's a really interesting idea. Appreciate the thoughtfulness here.
Yeah, thanks, sir. The next slide has just some information that we provided in the level of payment to kind of illustrate essentially the impacts of a potential cap on medical pharmacy. So the black line at 120%, and you can see it where it's lying. we have the three different settings here. Outpatient hospital for those who are capped at 200% of Medicare. We have outpatient hospital exempt, and then the office physician setting for these medical pharmacy drugs. Some of them aren't going to necessarily be able to be administered in office versus facility, depending on the types of drugs. But wanted to give you a look at the potential savings here. Another thing to note, because Moda and Kaiser did not split out medical pharmacy specifically for the facility, the outpatient hospital, we did kind of show their overall average. So it's actually probably lower than what you see here, 200% for those subjects to 1067, but it is, I think, based on our data, above 120%. Kaiser does not have much, at least in the data, based on outpatient hospital. Most of it's in office physician. But you can see there, even in the office physician, 120% would be essentially the level on the far right, level where Moda is essentially paying and Providence is paying for these services. So it's not really much of a change there. But for Kaiser, in the vast majority of their services are medical pharmacies being provided in the physician office. It is, 40 points higher than what 120% of Medicare would be. And then, as mentioned before, for outpatient hospital, depending, especially on those in more rural areas, we do see some payments for medical pharmacy up pretty high, above 200%, or definitely above 120% in this case. So this is where some of the savings potentially would arise if this were to be implemented. So in terms of reference-based pricing, I think medical pharmacy is definitely one, because as we talked about in some prior presentations, it's a little bit more of a commodity. There is, 120% of Medicare would be giving a profit, a listed profit at least to these providers, to these facilities. But if there's a certain set cost, like it's based on the sales price, right? So that's the price that the drug typically costs, and you're potentially paying more than that. So it's a guaranteed profit in this case. But some other services, you could do something similar to that, like for on the next slide, where in this case, if there was certain to be some services which are potentially administered in various locations, depending on the how it's done, it's potentially there's cost differences. And so one example here is an outpatient event called for CT scans for the abdomen. So potentially there are, these services are being performed, and they're coming in, well, they're above 200% Medicare, even in the office as well as a facility. And that facility is a combined, exempt, non-exempt. So you can try to drive members to lower cost settings and to lower cost providers as well. Or, as the 200% Medicare bill has worked, basically say, hey, these services shouldn't be paid this much, whether it's a legislation or in the case of what OIP did with certain knee surgeries and bariatric. We're not going to pay more than this. We'll contract with we'll pay up to 150% of Medicare. Say that's your price. And it's like, if you're willing to accept it, that's fine. And you'll be in network. Otherwise, you'll be considered out of network for these types of services. And so that's one way to do it for the knee and hip surgeries, or the hip knee surgeries and bariatric for OWEB. Basically, I think all of the facilities came in and accepted that price. So potentially there could be disruption, but trying to get those, if you state your position, there's potentially people who are going to accept that rate in order to get the services, to get the members from OIP and PEP to join them. Robert.
So my question is based on a comment you just had on if a provider doesn't want to do 150%, they won't be part of the network. How does that impact Kaiser then?
Yeah, that is a very good question. I would probably say that they would, I don't know. I'm guessing they push back. I don't know if I want to go into more of that, especially with the RFP kind of going out for PEP, but they do set their own rates, right? And I think legislation, when the legislation came in for 200% Medicare, they had to accept it. And that's part of the rating. That's part of the pricing for OAP and PEP. That's I don't know. That's one way of doing it, I think, for Kaiser, right? Legislation in this case. Beyond that, I guess we could talk to them and see what they have to say.
Thanks.
Yeah, and there's definitely, the way that you're trying to implement it matters, right? I think you can try to ask Moda, Providence, Kaiser to contract to pay at certain levels. It might not, it might not work. You can dictate that. You can have legislation, or there's actually point solutions out there. There's certain vendors who contract, especially with like COEs, like the knees, hips, those preference sensitive services. There's providers out there that contract with providers who are of good quality, but are willing to accept prices below to get that volume. For some, I've heard it come in as low as like 125, 130% Medicare for those like knees, hips, other types of surgeries. For those who do COEs for cancer, they do try to keep to essentially a little bit above that 120% Medicare level, to prevent essentially to drive members to those providers and to keep costs low. And so there are different ways you can do this. So you could hire a third party if the plans aren't willing to do this, or you could ask your friendly legislator to help come up with a bill to help implement this for OAB and PEP. So those are a couple different ways to do it. And they definitely have their side, unintended consequences or things like that you have to monitor. But there are ways to do it. Any comments or questions before we move on? Okay. There's one more, I think, slide. If we move on to the next one, it's colonoscopies. I think this is one that we've highlighted in the past, at least for PEB, but it's one that I think, maybe is a little bit easier example for people to understand. It's like, okay, if you get a colonoscopy, how much does it pay? It's like if you take a look at the percent of Medicare, you can see that for ASCs, the ambulatory surgical centers there on the left, it's a little bit below the hospital, but the hospitals the facilities get paid more than the ASC. So there's actually more savings potentially to be achieved here, in addition to the lower percent of Medicare reimbursements. And so if you set savings for some colonoscopy events, you can save, potentially up to millions of dollars. I mean, these are events that happen quite frequently, and the costs can vary from like $2,000 to like $6,000. And so they're services that can be performed in the ASC very easily to save money for OAP and PEP members. So this is another area. Okay. Next slide, please. Oh, Margaret.
Yeah, Emery, one thing I just kind of want to highlight too is we look at these graphs and kind of see these sort of overall like average numbers is typically when you start really looking into the data and start drilling down on reference pricing. I mean, what you see is a range, right? So some colonoscopy providers are potentially already at or below that 150% of Medicare level. And then there are some outliers that are potentially significantly higher, many multiples higher. So when you really if you identify an approach you really want to tackle and drill into, sort of like the next steps is really looking at that distribution to some degree and sort of seeing, okay, like, well, depending on where you set the reference price, like what percentage of providers are already operating within that or very close to that, and then, you know, how does that compare to outliers? So I just want to flag that, like, you know, sometimes when you set, let's say you set that reference price at 150% of Medicare, that's not necessarily, there may already be providers that are operating for that. So it's not like it's like this automatic, like, oh, you know, setting a lower price across the board for everyone, necessarily. So just kind of a nuance to think about as we kind of think about, you know, next steps and potentially further analyses in terms of how to think about the data.
Yeah, and setting that correct price, whether it's, you know, percent of Medicare or it's even like a dollar amount, right? Looking at that data, definitely. And it may vary by the region, location. But that would definitely be the next step to try to find that the correct rate that would make sense in this case. Next slide, please. Some of this already talked about in terms of there are vendors out there that do this. So that's one way to look at it. It's to, you know, essentially set the rates or drive members to providers who are willing to accept those rates. There are other services that are done based on essentially reference-based percent of Medicare. Network reimbursements, negotiated discounts are kind of tied to that. It's maybe a variant on the Colorado program where they have essentially paid cash. If you take a look at different providers and the prices, there are other plans that look at, okay, well, how much is your price different from whatever our reference-based price is, and we're going to change the cost sharing based on that difference. So there's other ways to talk about it, but the simplest is essentially to set a rate, and that's the rate that you want to contract at. But that's one possibility here. And just want to bring up the fact that Vermont is actually doing that. Okay, next slide. So site neutral payments, it's kind of like reference-based pricing, but it's slightly different. It's kind of variant on this. So, you know, as you know, healthcare is delivered at different rates depending on what services are done. Talked about, you know, ASCs being paid lower than outpatient hospitals. Highest payments essentially are at inpatient settings. These services that we would potentially look at for site neutral payments are those that can be effectively and safely delivered in lower acuity settings. Some situations, yeah, you do need to go inpatient, but let's say, for example, you know, with knee surgeries, it's like, do you need to go to an outpatient facility, hospital, or can you do it in an ASC? And what's the pricing difference there? In many cases, the ASC is going to be just, it's not necessary to go to a hospital versus an ASC in this case. So site neutral policies generally set that payment rate at the lower acuity provider rates. So it doesn't vary by setting, but it's basically, this is how much in total we want to pay for this. So like if you go get lab service maybe in a off-site location versus in the hospital, it's like, well, no, we don't want to pay 50% more, 100% more for that lab service just for that quote unquote convenience of doing it in the hospital. You know, it's like, this is the price that we feel like it should be paid at. And so that's essentially site neutral. It's something that's been kind of gaining momentum. Medicare has been talked more and more about, but there have been political roadblocks around it. And then you can see this potential savings for site neutral payments down there for Medicare in 26, about $6 billion over 10 years potentially. So there are savings to be had based on trying to make payments site neutral. Have some examples I believe on the next slide. So again, talked about this, the knee arthroscopy, so kind of a knee procedure. Taking a look at the cost per episode, you can see the absolute dollar difference, right, between an ASC and an outpatient hospital. So outpatient hospitals essentially more than double the price on average, based on the data we got from Meritive for each of these outpatient events. And so potential savings, if you set prices at that ASC level, kind of like at that 5,000 or so, you could save $1.1 million. So is it, there is definitely some member impact, right? You have to go from outpatient hospital to an ASC, especially in locations like Portland or other places, Bend, bigger cities. ASC is not going to be far away. But you do have to potentially change the provider if the hospital is not willing to accept those rates, but you can save money if you want to pay at the ASC level. Next slide. So another one, this one might be a little bit different in terms of hysterectomies. There are some that are being performed in ASC. There might be some that have to be performed outpatient hospital. But a lot of these may be just based on where the OB-GYN has their admitting privileges, right? Or some, where they just practice. And so there is definitely a difference in the cost. There's a significant number that are performed in ASC, more so in the outpatient hospital. But you can also, again, see the cost difference here between an ASC and the outpatient hospital. If all were paid at the ASC level, you could get $4 million, but depending on the situation, you might not get that much savings. But there's a lot of money, a lot of cost difference between an ASC and the hospital. Again, about double the price or double the price more for these events. So it's a variant on, it's essentially setting prices, right? How much you're willing to pay or getting a provider to negotiate at that. And some COEs do that, right? It's like in terms of bundled pricings, and it doesn't matter where the facility is, whether you're in the hospital or ASC, but some of these services could be performed for cheaper at lower cost settings. Margaret.
Yeah, just quick question. So on that
Mhm.
outpatient hospital side, I'm assuming that rate is like right around 200% of the Medicare rate. Pretty close to. I'm just wondering, and this, if you don't know offhand, it's okay, but like on the ambulatory surgery side, do we know what that our amount is averaging as like benchmark to what Medicare would pay?
Uh, I don't have numbers off the top of my head. I mean,
Okay.
James, I think is on. I don't know if you can try to look it up, but we can definitely get back to you on that.
Yeah.
Yeah,
And of course,
the outpatient hospital might be
yeah.
above 200% because of rural areas.
Yeah, okay, sure, because that's not just the capped, but also exempt
Yes.
facilities. Yeah, and
Mhm.
of course the ASCs are not under Senate Bill 1067, but I'm just kind of curious, like what are we averaging relative to Medicare for those services? And I see James has his hand up.
Yep.
Yes. Let me pull it and give you the best answer I can. The outpatient hospital is both more expensive and a higher percent of Medicare, but we are not really coming in above 200. I think it's probably predominantly weighted by the 1067 hospitals. The ASCs, we see a little bit of a range, but I would say less than some of the numbers are in the 130, 135% of Medicare. So a lower price and a lower percent of Medicare.
Thank you.
Yeah, so Sally, I think, yeah, it is kind of like trying to set rates right at the ASC level or something kind of close to that. Again, Margaret, I don't know. I mean, I keep bringing up the example of OEB, right, with the knees and bariatric, right? There was a worry about prices being set too high, but or set. I mean, the prices would be they wouldn't accept it because the prices are set too low. But it wasn't. I mean, they all came in. They all accepted the rates, and they didn't want to lose access to the members, right? And so there is potentially the possibility of moving in that case, or at least trying to leverage your purchasing power by stating this is dictating. This is this is basically what we think it should cost, or this is we don't want to pay more than this. Sean.
Yeah, this is probably a rabbit hole, so I'll just ask, and if you don't know, then we'll just tackle it later. But I realize I've never actually asked this question. So we know that a big part of increasing costs across time in Oregon and the United States is industry consolidation. This is well documented. So I'm wondering, who owns the ASCs? Like, are they part of a hospital system generally? And if so, why didn't they just price them the same? Because they're the same owner. Like, what is it about them that makes them cheaper? You know what I mean? Or are they actually competitors? Are they actually competing? Um, because they're just totally different network, not associated with the hospital systems, doesn't go into the same profit center. In which case, if we pass this or did something like it, would there then be a industry consolidation pressure for the hospitals to go gobble them up if they haven't already? So I'm just curious, like, how does that work? Like, why is there a difference like that?
Um, I'm not sure. I'm not sure I know enough about everything to want to state, exactly. I do believe in many cases they are competitors. Um, but I mean, I don't know, James, I think you have more history than I do on the Medicare payment system. But I mean, I don't know if there's anything you want to add on that, or Margaret, anything you know. Um,
I don't have anything too definitive, Emery, but I think that the trend for the big health systems to buy practices does include some ASCs. I think they continue the regulatory nature of how they stay in ASC instead of being called an outpatient hospital off campus. I think those details are beyond me, but I think that there are both independent and health system owned.
yeah, and yeah, I don't know. I mean, we can definitely look a little bit more into it. I think uh,
Okay, it's a big.
dialysis centers,
As I
right?
said, it was a big topic, right? That's
Yeah,
a can of worms. But
yeah.
I just as a follow up, not for now, but just as you're following up on that, it would be interesting to know if any other states, as far as you know, have done any kind of uh, protection legislation, anything like that, since we're talking about site neutral. Yeah. Is there anything in any of the states where anyone's experimented with basically protecting these the independence of some of these sites, in other words, antitrust, anti-consolidation type legislation where it's like meant to keep things separate and not consolidate. And you do not need to even take a swing at it right now. It's just a thought of like if anyone's ever experimented with that. But if over time we even lose this distinction in price, then it's like the whole game's over anyway on this topic anyway. So I'm just kind of thinking ahead of like where this might be heading. So that's all.
Yeah, yeah. I'm I'll look it up. I want Margaret, I don't know if you know the legislation. I could have sworn there's something, maybe it's not in Oregon, maybe it's someplace else where there's like legislation about, I don't know if it's private equity or hospital ownership of certain facilities. If it's above a certain percent, then it's not considered like off campus or ASC. So there's definitely some stuff around it. But we'll have to I definitely would have to look it up to
Uh,
get more information there.
Yeah, agree, Emery. That's certainly something we can take away for further research. I was going to note, I know NASHP has some model legislation around site neutral payments, and they have a webinar on their website. I'll go ahead and post that link in the chat in case it's of interest for anyone.
Thank you.
It was a good webinar. I actually saw it.
Glenn, did you have something?
Oh, I just wanted to say there was legislation last year that passed that dealt with corporate and private equity ownership of health systems and healthcare providers, and it passed here in Oregon. So there has been movement here in Oregon to really prevent that kind of vertical integration through private equity and really corporate ownership of healthcare providers.
Thanks for that, Glenn. Maybe worth having a little couple minutes somewhere on an agenda somewhere, or maybe just offline to dig into what that really did and didn't do. That'd be great.
Yeah, I'll go back
Appreciate
and
that.
look up the legislation and see, kind of get a better sense of
Yeah.
exactly.
Thanks.
Yeah. I think one area, if I remember correctly, is like dialysis. That was a big one, right? Purchasing up those dialysis centers and then trying to raise the rates. So, but implementing a maximum payment might help in that case. And a lot of people do. I think they try to get members onto Medicare for the dialysis, get your SD, and then you can save some money that way. But I think there's some programs around that. Okay. Next slide, please. Oh, yeah, there's the Senate bill. I guess someone put a comment. Rick put the comment in the chat about the Senate bill. Okay. So this next section is what we are calling high value provider networks. So it's essentially what we were talking about with Garner, right? Trying to get high quality, low cost, efficient providers and driving members to it. What OpenPep is doing is to essentially incent people to it. This is something that we're suggesting as something for the boards to look into. We're not saying definitely do this, but there are state programs out there, and it's like variants of what we've been talking about before, and we talked about it, especially with Minnesota, in terms of their state program. But essentially creating networks, like tiered networks, where you are trying to expand the use of high value providers. So the best providers, the cheapest providers, the most efficient providers would have the lowest cost sharing. You wouldn't necessarily have to go through and look them up. Well, you would probably have to look them up, but it's the network. It's the network that you have, and it would tell you which tier that they're in. But you wouldn't get necessarily reimbursed for HRAs like the way the Garner currently works. You would actually be saying, okay, my deductible would be $0 or $200 or whatever. My copays would be a certain level, low level, just to go to those providers. And then you would also then potentially have other tiers where they're not that highest quality, low cost providers. You could do what Minnesota does, which I think they have 4 tiers of different types of providers, and then the cost and quality differs by each of those, and the cost sharing does as well. So that's something that potentially OpenPed could look into. It would then hopefully drive more and more members. It's more of a stick rather than the carrot that the Garner has for driving those members to the top providers, but it helps differentiate and maybe reduces trends as more providers use those top providers, those high quality providers, and it improves the care of those members. Next slide, please. So in terms of just like a graphic on what high quality is, basically you have quadrants, or you can have percentiles or whatnot. But basically you segment providers into essentially, those who are high quality, low cost, and those would be, top left in this case, this graph. Those are the Garner providers, essentially, right? Those top providers, those very efficient providers. But then you also have high quality but higher cost, and those are to the right, and low quality but low cost, and those are bottom left. Those might not be ideal, but at least they're not D, which are low quality and high cost. And so you're trying to drive members out of that D. Garner is basically focusing on A, but you could also kind of flip the script to drive members away from D, or you just don't contract with them. So you're just trying to improve and just move everybody over into the higher quality and higher cost providers. And that's something that Minnesota has done. Sarah Drake's on the call. If you have any questions about Minnesota, she's actually on the plan, so she can provide some information about it. I've talked with her a bit about the plan, but if you have any of those questions on impacts on members or how you access care, she can definitely answer those for you. The next slide is also graphical representation of this. So this one talks about Chicago. It's kind of like a Mercer slide to kind of illustrate essentially primary care, efficient, high quality providers versus non-efficient, not high quality providers. So you have the different quadrants, top left, bottom right, and then the two kind of okay ones in top right and bottom left. And you can see the patient volume of those providers. There's actually 38% of members, patients going into those low quality, high cost providers. And then 31% are in the low cost, high quality providers. And you want to move that 38%, hopefully into that 31, but even if they move into the 12 or 19, it's just still going to be better care in this case. So that's essentially what we're talking about. And hopefully, as you drive those members, however you do it, it's going to provide better care, better quality, and better outcomes, hopefully. There's a couple of bullet points there. The question about access. Yeah, that's definitely an issue. Oddly, in Chicago, the top 10 providers and the bottom 10 providers, they're actually seeing less than 10% of the patients. I don't know why, but that's the case. So there is some, I guess, ability, some access for those top providers. You just have to have the members find them and then go and see those providers. But they're not seeing the percent of patients that they're, where they rank in the percentile would seem to indicate they would have. But that is one way, that's a graphical example of what we're proposing in this case. Next slide, please. So next steps, we've talked about these. There are hopefully some things that ring. It seems like some of them ring true with Sean, and hopefully some others as well. But it's a lot of this has to do with, well, is this something you want to explore? And if so, how would you want to explore it? Would you want to do it via legislative concept or some other way that we could develop further, like those high quality networks? We do have some potential ways of developing that on the next following slides. But I'd like to, I guess, maybe open it up to all of the workgroup members and other board members who aren't necessarily part of the workgroup, that are listening to, provide your thoughts, because we want to know, does any of this ring with you? And where do you think there might be the most value in attacking in this case?
Ask a question first. So the high value networks, how is that different than centers of excellence? Just so I have a better basis of
it is definitely on the same spectrum, right? It's centers of excellence is a little bit more narrow. The higher value would be a wider subset. So it'd be expanded centers of excellence, or even going to what Garner's doing, right? It's across the basically entire spectrum of providers, from primary care up to to the most niche, the cancer pediatric cancers specialist. Actually, Sarah, I guess, maybe you could provide a little just background on what Minnesota's doing, just to put you on the spot in terms of how theirs work.
Yeah, sure. And just for background, I am enrolled in the Minnesota Advantage Plan. My spouse works for the state of Minnesota, so that's my link there. But the way their program works is that at open enrollment every year, you get a list of there's either 2 or 3 carriers to choose from. And then within each of those carriers, there's different primary care clinics that you can choose from that are tiers 1 through 4, like Emery said. If you choose a tier 1 primary provider, what comes with that, it's a whole network. And so any specialists that you need to see needs to be referred through and have a contract with your primary care provider. In my experience, there's not a lot of exceptions to that. You need to stay in the network. If you choose tier 1, you have lower deductible, lower copay, lower cost share kind of across the board than if you choose a tier 2, 3, or 4 provider group. So there's different tiers depending on which group you choose. Minnesota does allow you can switch networks through the course of the year. I think it's once a month or every 2 months. If you want to switch networks, that option is available to you. I don't think most people do that. But yeah, once you've got your network, your ID card has who your primary care provider and network is, and then all your care needs to be arranged through and approved by that group. I will say it is, by choosing a network that's tier 1, the savings can be pretty significant. Sometimes that means you don't get to go to the specific specialist that maybe you want to. But my understanding is it has saved the state a lot of money. And once you understand how it works as a member, it's actually kind of convenient because everything needs to go through your primary care provider.
And it's a little bit, Robert, it's a little bit like, accountable care organizations. I don't know if how much you know about those and, heard, right? Essentially, it's like in this case, it's like, I don't know if there's probably some accountable care organizations where it's like all through, right? The entire provider system, like from the primary care to the facility end, they're all contract together, but they're higher quality, lower cost. And then you're essentially incenting members, right? You're creating that cost share differential for people to go see that and to save money overall in this case. So that's a little bit more of a, end to end. There are other programs out there, with Garner, if let's just say it was the only network, right? Or it was like it gets turned into a network, and you would then need to look at each type of service that you're looking for to find a top provider and then use that provider for a lower cost. It's not necessarily you get referred to it because it's not end to end, but you would have to do it each single time. And maybe your cost sharing would be lower there. There's other variable copay programs. I don't know if that was presented or if you know about them, but like variable copay programs essentially is a more harder carrot. It's like you have the app, and if you want to take a look at services, you look it up, and it gives you different cost shares for seeing different providers, and those cost sharing, that copays vary based on the cost and quality of those providers. So the worst ones might have a really, really big copay, and the best ones and the lowest cost price providers that have a very low copay. And so it's much more, I guess, stark in terms of how they're trying to drive you to those lower cost providers. But it's very, so there's various ways of doing it. If we go to the next slide, I think the section on the right kind of just illustrates it. You have to overlay with Garner under high value providers. That's what you currently have, right? It's just potentially expanding that or to make it a more bigger program. I don't know if it's a bigger program, but it's more, I guess it's more mandatory program in this case, right? Because you would essentially, if you do the Minnesota, you create the networks versus just having that overlay and having the member going and doing it on their own. And then I think we talked about some of the other examples there with the cost sharing differences. And then as mentioned, I think a little bit earlier, cash payment incentives in Colorado. So basically you look at the app, you choose, let's just say you choose to have your colonoscopy done in ASC, and that's cheaper than the facility. Here's $250 to you. And that's just made up example, but that's essentially what Colorado's doing in this case. So that's ways to try to potentially implement a high value provider network. Sean.
Yeah, just for my 2 cents, I would actually prioritize this as it's laid out left to right. And just the amount of cost pressure that we have bearing down on us over the next 5 years, I would hope that we would consider all three of these. These are all three good buckets. It's just a matter of how much time we have as far as capacity for both the boards and also Mercer and staff. So therefore, I would prioritize them in this order. My reasoning for that, and I would suggest reference-based pricing, that we're heading towards a legislative approach, in my opinion, because in my mind, if the carriers could bargain hard like this with their contracts, they would already be doing that, as they have heard us say. Like, we really need these costs to come down, and the response we get back is like, wow, that's really hard. So I think legislation is we have a proof of concept on one. There's some other states that have some momentum on it. It just kind of feels like the time has come. So that's what I would say there. I had a few follow-up questions on the site neutral pricing thing, because I would just want to understand, what is that ecosystem a little bit more, in order to understand what some of the potential unintended consequences may be. And I had some of those same unintended consequences questions about the reference-based pricing originally, which is why I said earlier that I was surprised at how well it worked, because I also had some of those like, well, wouldn't everyone's just prices rise to the thing? And there was some of that, but then we adjusted and so on, and it's more or less worked, at least to some degree. And so some similar questions on site neutral pricing. So that would be good to just follow up, but it also feels worthy of continuing. It also seems like that would be a legislative approach for the very same reasons. But that's my opinion. And then the high value providers is, of course, worth talking about, because I mean the chart, is always such a tempting chart to see, right? You have like the 4 quadrants, and you're just like, wow, why would anyone pay for that worst quadrant, right? But I'm just and so I'm saying, yes, let's continue to explore that. And I'm also remembering our experience with our attempts at the centers of excellence, and that was basically where we ended up, which was, well, the quality thing, devil's in the detail, like figuring out who is high quality, much less who's high cost, which is its own thing, because then you got to bundle payments, because who's including which, and so on. And you get into that whole game. And so we ended up in this moment where we were like, well, actually, the easiest thing to do is maybe just cut off the bottom 10% of providers who just regardless of debate about who is at 50 and who's 49 and who's 51, instead of that, just take the bottom chunk and just be like, out, and maybe that's good enough. And that's where we landed there, because it was clearer in the data. So worthy discussion, but boy, that's a difficult, we spent a long time on that. So I have a little bit of caution on that one. So that's why the priority from left to right. So that's my 2 cents.
Thanks, Sean. Any other members with comments, questions? In terms of the high value providers, yeah, I think us trying to create our own metric, it was great learnings, but it is difficult. I mean, I think Garner has more money to do it than I do. You know, there are definitely firms out there that are doing things like that. And you know, trying to find the right partner. If you want to do something with high value, I think it can be done. Yeah, but it will, I think, to my earlier point, it will potentially cause disruption, right? It's going to cause member change. And unfortunately, I'm not sure we're in a situation where we can have the status quo and keep going and be able to meet the 3.4%. So it's a question to the boards, really. It's like we need to save money. How much how much do we need to save, and how much member impact would be tolerable in order to save that money? Love to be able to just get a legislator to say, well, this is all we're going to pay, but I'm not sure that's going to happen. Ali.
Yeah, that's a great point, Henry. I just wanted to mention that the our medical pharmacy legislative concept has been moving through the health authority, then it moves on to the governor's office for consideration, eventually the legislature if it makes it through those first two hurdles. And they are hearing legislative concepts this week as far as OHA and their consideration. So we should have, you know, we've talked a little bit about this being kind of waters politically legislative concept, something a little bit different than we've tried in the past. So yeah, we'll keep the IWG and the boards up to date on the progress, but we're hopeful. So far, so good.
This is actually the last slide, so I guess I'm making a final call for comments, questions. We can definitely discuss further. Talk to staff, Margaret, Glenn, Ollie, others, and then we can have that conversation. And Sally and Sean, I'm sure we'll be talking more about this. But yeah, if there are no other questions, comments, I'll turn it back over to you, Chair.
Thank you so much for that. The next item up on the agenda is public comment. Did we have any public comments?
Rose, I'm not
No.
aware of any. Yep.
No,
Just
no
checking. I was
public
gonna say-
comment.
Perfect. Thank you, Rose.
I didn't see any either. Just wanted to make sure. Okay, well, that completes our agenda for today. Our next meeting is Wednesday, May 27th from 1:30 to 4 p.m. I look forward to seeing you all there. Thank you, everybody, for coming today.
Thanks, Sally.
Thank
Thanks,
you.
everyone.